So hi, everyone. Thanks so much for being here this afternoon. My name's Jen James. I'm a sociologist. I'm an assistant professor at University of California, San Francisco. Welcome to our monthly community forum. I feel like we missed the last couple months. There was some illness, there was some scheduling things, so I'm glad to be back in our usual cadence. As we've been talking about, for those joining, if you want to introduce yourself in the chat, we have folks here already from sort of all over the country, which is exciting to see. And if you want to let us know what brought you here today, why you're interested in either breast cancer or the specific topic, we'd love to hear it. Go to the next slide. So the mission sort of the wisdom study, which we'll talk a little bit more about, and really the reason we're having these forums is that many of us researchers and healthcare providers have a goal of moving together towards equity and better outcomes in breast cancer for everyone. And I believe, many of us believe, that really starts with community, with coming together, understanding different sources of wisdom, different questions people have, different experiences, and learning together. And so that's what we're here to do today, is learn from both clinicians who have expertise in breast cancer research and care, as well as from patients who have expertise in both lived experience and, in the case of our speaker today, scientific expertise as well. Let's go to the next slide. And I think the reason for this study in particular, the wisdom study, which many folks here are affiliated with, and for our care and a lot of the research in this area in general, is we know that breast cancer isn't just one disease. Sometimes it's very aggressive, sometimes they are well treated with existing treatments. And particularly when we're talking about younger women, which is our topic for today, we know that they can be at risk for really aggressive cancers. And we want to better understand that, we want to change that, and we want to support folks who are going through it right now. And that there's a lot of things that contribute to breast cancer risk, some of which we understand really, really well, some of which we don't understand at all yet. And we know that many people who get cancer might not have any of those strong indicators. Family history, which was once the predictor for breast cancer, that was how it was seen. We know now there's many other pieces of the puzzle. And also that some people who have hereditary risk, genetic risk, might have a gene mutation, or their genetic risk might not have a first-degree relative. So there's a lot we still need to understand about who's getting cancer, why they're getting cancer, so that hopefully one day we can stop people from getting cancer and also treat people who, once they're diagnosed. And we also know that breast cancer outcomes are not the same across all communities, right? There's huge disparities in terms of race and ethnicity, in terms of access to health insurance and other, social determinants of health, as well as structural things like racism and classism and sexism that have led to many huge disparities in what we know about different populations and how we treat different populations, what access people have. So we need to do, there's a lot of work to be done to try to understand and unravel that and improve upon it. Yes, and someone just messaged me asking me to slow down, and I definitely will. I have a tendency to speak too quickly, so thank you for telling me, and always feel free to let me know when I'm talking too fast. So we're gonna have a great discussion today. As I said, I'm Jen James. You already heard from me. I'm gonna introduce our speakers. If I can pull up my bios, and then we'll get started. So I'm gonna start with Morgan Mitchell. So Dr. Mitchell, Morgan, is a survivor, was diagnosed with breast cancer at the age of 35. She has a PhD in biochemistry, and as a scientist, she really values the role of research. 34. Thank you for the correction. My notes were wrong. Even scarier and harder, and I'm so excited to hear about it. So Morgan strongly supports participation in clinical trials and research, as well as for women to be their own healthcare advocates and stay vigilant about breast health. And she'll be joined by Dr. Jo Chen, who specializes in breast cancer. She has a special expertise in tumors called HER2 positive, although I feel like I saw an email that she looks at many other types of cancers too, not just HER2 positive tumors, but specifically looks at some aggressive types of cancers. She sees patients and run trials in all breast cancer subtypes, and her primary research interests include breast cancer in young women and fertility problems related to cancer treatments. She leads the I-SPY trial for the UCSF site, which is a trial that has arms across the whole country and sort of started here at UCSF. And she's also a busy mom of 3. So our format for today, so we're going to hear from our two speakers, and really our goal is for this to be a conversation. I have a whole bunch of questions I want to ask them both, but we really want to hear from you. Feel free to put questions in the chat as we go, and I'll try to interject them. And then when we get to the discussion, feel free to raise a virtual hand or wave your actual hands, and I'll try to spot them if you want to participate out loud. While you're not speaking, please mute yourself so everyone can hear more easily. As we said, there will be a recording. If you want to say something not on the recording, feel free to do it via message. And at the end, we are going to have a survey that's going to pop up asking for some of your feedback on this session and what you want to hear about in future sessions. And oh, great. And our second speaker joined as well. I think we can skip through this. This is going through some of what we've talked about in prior forums, which are available if folks want to know about them. But we've talked about breast cancer in the Black community, who's at risk for breast cancer, many different topics. And this session is coming as sort of a mini series on breast cancer across the life course. So we sort of talked about breast cancer in middle age. We're going to talk more about breast cancer and in older ages. And today our topic is young women. So without further ado, I'm going to hand over to our first speaker, Dr. Shan.
Thank you. It's really a pleasure to be here. Thank you so much for the invitation. As Dr. James said, I'm a medical breast oncologist at UCSF although I see patients of all ages and all subtypes, I do have a special interest in young women in particular, and in particular, the impact of the diagnosis and treatment on fertility and reproductive outcomes. So my goal today is just to give you some background about breast cancer and in particular in young women. As Dr. James says, this is meant to be interactive, and so feel free to ask questions and hopefully we'll get through all the slides. If not, that's okay too. So breast cancer in young women is actually increasing in incidence. There are over 27,000 breast cancer diagnoses diagnosed in women under the age of 45 in the United States a year. That's 11 to 13% of all breast cancer diagnoses. And if we're looking just at women under the age of 40, makes up about 5% of all breast cancer diagnoses, or about 12,000 cases a year. If you look at the trends over time in the bottom graph here, it's looking at from 1975 to 2019. If you look at the blue line, that is the incidence, meaning the number of cases of breast cancer over the years. And you can see it's slowly trending upward. And you can see in the box on the right that for women under 40, 0.5% increase per year since 1994. And as the women get older, you can see that increase gets smaller. So there's a disproportionate slight increase in incidence in younger women than older women. The good news is, though, the breast cancer survival continues to improve. So if you look at the bottom line, the green line, for between 1975 and 2019, you can see that line slowly dip down. So lower incidence of death from breast cancer. And if you look at women just under 40, you see about 3% decrease per year between 1986 and 2010. So that's really great news. And that's a testament to all of the advancement in our systemic therapy, detection, local regional control. Next slide. Breast cancer, if it does develop in young women, based on the studies we have, we know that it is associated with higher risk features. And what do we mean by that? In general, women who are younger, who are diagnosed with breast cancer, present with larger tumors, more likely to have lymph nodes involved at the time of diagnosis, more likely to have what we call high-grade tumors. These are the more proliferative, the faster growing tumors. And as a result, we see that when patients are diagnosed, that they have a higher stage. Remember, cancer, when they're diagnosed, stage from stage 1 to stage 4. The higher the stage, meaning the more disease, the more it has spread. And for younger women, it tends to be higher. We also find that there are more aggressive subtypes associated with breast cancer in young women. Breast cancer is no longer one disease. It's actually many diseases based on certain biological features. And one of those biological features are the receptors. So estrogen receptor, progesterone receptor, and HER2 are the three receptors we test for that really tell us a lot about the biology. The ones that are triple negative or don't express any of those receptors are the more aggressive. HER2 positive, also more aggressive, although we now have some good targeted therapies. But we see these subtypes more often in younger women than older women. We know that if you had tumor features that looked exactly the same between younger women, and like a young woman and an older woman, there is independent increased risk just with age alone, meaning if you control for all the other things, size, lymph node status, grade, the receptor subtype, and all of those things were held, stable between an older woman and a younger woman. There is independent risk just from being younger. This graph on the right is another demonstration of how younger women present with higher stage disease. So if you look at the turquoise box, ages 15 to 39, you can see that there are, compared to the green and pink bars where they represent older women, that there are fewer localized diseases, that's stage 1 and 2 in younger women compared to older women. And as you move to the next group, regional breast cancer, where it involves the lymph node, this is a higher stage, usually stage 2 and 3 cancers. You can see proportionately there are more younger women are more likely to have regional disease than older women. And then in 5% of cases, we actually detect distant disease at the time of the initial diagnosis. And you can see that more often that's seen in young women than older women. So again, an example of higher risk features at presentation for younger women than older women. Next slide. Although a breast cancer diagnosis is really difficult and terrible and life-changing for all women, we know that for young women in particular, there are unique challenges. There are many reasons for this. They're listed here. One of the most impactful differences is that for many of these women, we are putting them into menopause early. And this might be because of the chemotherapy inducing menopause in these young women. And in our higher risk patients, we also will put women into menopause with an injection for hormonal therapy. So these menopausal symptoms are difficult for women without breast cancer, and the natural menopause process actually takes 10 years. When young women are put into menopause acutely because of chemo and our medications, that literally happens overnight. And as you can imagine, especially the younger the women, because young women have high levels of estrogen, putting them acutely into menopause, literally over the course of a couple of weeks, can be really difficult with hot flashes and cognitive changes, mood changes, weight gain, night sweats, joint pain, fatigue, really, really challenging, really real issues. For young women, fertility and the uncertainty of future pregnancy is very stressful. We're diagnosing women at a time when they're oftentimes doing family planning, and this is a very big interruption with a lot of uncertainty. So at this time, for early stage patients, especially, we really encourage women who think that they might be interested in future childbearing to see a reproductive specialist and consider doing egg harvesting if that is of interest, and doing that before we start treatment. We do know that when patients do that, that results in less regret down the road, and that's really, really important. For younger patients, the impact of genetics and the impact of genetics on future fertility is more often relevant, and the impact of genetics on surgery options and surgical decisions, as well as treatment. Now, we do have specific treatments that are just for BRCA carriers that are more relevant in young women than older women often. We're also diagnosing women at a time when they're growing their careers. They are building, finding partners, and this is a huge interruption into their social functioning. that can be a huge source of stress, psychological and physical downstream effects. So, really unique challenges, heightened concern about body image, finding a partner and dating and intimacy, sexual dysfunction due to the treatments that we're prescribing, financial toxicity. That's another it's a toxicity that we don't often talk about and is less well studied, less well known, but especially in some patients younger don't have good health insurance, or if they have to take time off and medical leave as they're building their careers, or to have unstable work situations, the impact of a diagnosis and the healthcare required can be very difficult financially. And then, of course, the anxiety and depression associated with all of this. So because of this, the team for a young woman with breast cancer is quite large. And I've listed just some of the specialists here in the bottom right. Besides our oncologists, that includes surgical oncologists, plastic surgery, radiation oncologists. We oftentimes will refer patients to reproductive endocrinology, talk about fertility preservation, gynecology, to discuss how to manage some of the side effects, menopausal side effects, genetic counseling, psychology and psychiatry, integrative oncology. Women are very interested in supplements and wellness and acupuncture and some of these complementary therapies to help combat the side effects due to our treatment. As well as survivorship. After the acute phase, we do transition our patients to the survivorship program to really focus on how to move forward and how to manage some of the longer term side effects or the residual side effects from our treatment. Nutrition and exercise consultation. We know that and exercise is an independent benefit to reducing risk of recurrence, and healthy weight management is very important. And of course, social work. Next slide.
Just real quick, before we move on, there was one question that I think was based on the last slide that I want to take a quick pause. The question was about the larger tumor size. Is it because the mammograms aren't being done for women under 40 and therefore they have a chance to grow unchecked, or are there other reasons why tumors may be larger in women under 40?
Yeah, that's a good question. So there's many reasons. You're right that for most women, unless there's already an identified higher risk where they're undergoing early screening, but for most women, we are not doing mammograms under the age of 40. And so for younger women, most of them present because they feel it a mass. And as I said, oftentimes we find more proliferative, more aggressive biology in our younger patients, like triple negative disease. And when it's growing that fast, literally, these are women who say, I noticed this for the first time, a week ago, and there was nothing there, 2 weeks ago, because the tumors are growing fast. So part of it is that, yes, we aren't doing screening, but screening may not help, and this gets into the controversy of screening in younger women because of the biology of the tumor, more associated with younger women, where the growth can be fast, and so you're not really catching them with mammograms anyways, even if you are doing them. These are called interval cancers, where they would have developed in between mammograms. So it's, the answer your question, it's many reasons. One of them is they're not undergoing screening, and the other is just the inherent biology of the tumor being more aggressive and fast growing. Okay, so what are some of the risk factors associated with developing breast cancer? Of course, genetic mutations that you've inherited put patients at increased risk, and BRCA1 and BRCA2 are two of the most common mutations and most long-standing that we've identified and can test for. Depending on which mutation you can have a lifetime risk of up to 80% of developing a breast cancer if you have a BRCA1 or 2 mutation. And so in the column on the right, these are what we call relative risk. These are so a 3 to 7-fold increase in developing a breast cancer compared to somebody without a BRCA1/2 mutation. So that would be a 3 to 7 a relative risk of 3 to 7 is a 3 to 7-fold increase. So if you just have a first-degree relative, like a mother or a sister with breast cancer, that's about a 2.6 fold increased risk. And these are approximate depending on the studies. There's different findings, but these are just examples. We also know that patients who have a higher lifetime risk of estrogen exposure have an increased risk. And how do we define lifetime estrogen risk? So women who had early menarche, or the first period being under the age of 12, there's a small increased risk of 1.5. For patients who had their first delivery, their first child, delivery of the first child over the age of 30, because during pregnancy, you actually have more progesterone and lower estrogen. So the thought is if you delayed pregnancy and delivery, you would have a higher estrogen exposure because you've delayed it for longer. That's about a 2 to 3.5 relative risk. Later menopause, again, delaying the absence of estrogen. So menopause over age 55 associated with about a 2-fold increase. It's important to note that birth control use with OCPs, oral contraceptive pills, there has not been an increase shown to be an increased risk of developing breast cancer in premenopausal women using birth control. However, if you're a postmenopausal woman who have already gone into menopause, and then you're taking what we call hormone replacement therapy with both estrogen and progesterone, there is an increased risk of developing breast cancer of about 1.2 in the Women's Health Study. Interestingly, if you just take estrogen alone, that increased risk has not been demonstrated. Another risk factor, which is also less well known, is breast density. So this is an example I show here on the right. If you look at a mammogram report now, it's by law that radiologists have to report out on your breast density. And you go from A to D, from less dense to most dense. So A is almost entirely fat, okay? And therefore the mammograms can be more sensitive and pick up more because you don't get a lot of that background. Then B, scattered fibroglandular density. You can see a little bit of brightness and enhancement there. And then C, heterogeneously dense. You see more of the enhancement throughout the breast. And then you can see in D, this is extremely dense. And you can imagine it's difficult to see an abnormality behind there because of that dense enhancement. So we do know that patients with higher density do have a higher risk of developing breast cancer. Also, it is harder to detect a breast cancer because it's so dense. And you can see that relative risk, depending on the study, there's wide variation, but we've seen upwards of a 6-fold increase in breast cancer risk. We also know patients who've undergone biopsies for abnormalities on imaging have an increased risk. I don't think it's necessarily the biopsy itself. It's probably because of these changes that your findings on the imaging that led to these biopsies. And even though those are benign, perhaps it's a signal that there's more proliferative change and other changes going on in the breast. And atypical hyperplasia is sort of a precursor. These are cells that are dividing faster. It's not malignant, but we've seen that this pathology can increase risk of developing breast cancer in the future. Next slide.
And one more question that's in the chat. So are the risks the same for males who have the BRCA mutation?
The lifetime risk is not the same, but yes, men that have BRCA1 and 2 definitely have a much higher risk of developing breast cancer as well as other cancers. The lifetime risk, I don't think is as high as it is in women, but I'd have to go back and look at the exact number. But we definitely screen men in the same way. Okay. This slide is just to show you that for most women, so this is not just young women, many women will come in and say, I have some family history. So this is where, if you look at this pie chart on the left, there is the majority of cases here in the light blue are sporadic cases. These are patients who don't have much of a convincing family history. The pink are cases where there's a strong family history, meaning you say, my mother had it, or my aunt had it, or I have multiple, cousins, and so there's a very clear history there on one side of the family, but we don't detect a mutation based on the genes that we've already, identified. It's a suspected hereditary. It's suspected that a hereditary mutation has led to the diagnosis, even though we can't detect it. And then 5 to 10% of patients will actually have a detectable diagnosed hereditary mutation. Most of those, if you look at the pie chart on the right, are BRCA1 and 2. In the more recent years or decade, we've identified more of these genes, what we call high penetrance or moderate penetrance genes that have been associated with breast cancer. May not, the guidelines for how to manage them are not as well understood as for BRCA1 and 2, but we are getting there. And those mutations here are listed here on the right. So PALB2, ATM, CHEK2, P53, P10, BRIP1, CDH1. These are now part of a huge panel. You'll see that now when we send out genetic tests, we're checking 30 to 40 genes. But I would say in terms of what's actionable right now and how we would alter our management for screening or even treatment, it really comes down to, these 7 to 9 genes. Next slide. So how do we screen patients, in patients who do not have a diagnosis? It really comes down to what we believe your lifetime risk of developing breast cancer. And this is a very complicated question, and there are many different models that have tried to estimate this. And the Breast Cancer Surveillance Consortium is just one. There are many that have where you enter a lot of data about yourself, and it generates, what they believe your lifetime risk is. The well-accepted sort of high-risk definition is if your lifetime risk of developing a breast cancer is over 20%. And if that's the case, then that's when we would do annual screening mammogram and MRIs. And these are patients certainly who have a hereditary mutation, patients who have strong family histories. But it also takes into consideration breast density and all the other sort of factors that we've talked about in the previous slide. Next slide. What are things that women can do to reduce their risk of developing breast cancer? Again, patients who don't have breast cancer, what are some of the prevention strategies that we counsel about? Certainly, there are studies that have shown a number of lifestyle modifications can help. One is increasing exercise. There have been a number of studies where showing the more physical activity, the lower the breast cancer risk. And in general, we counsel about 150 minutes of aerobic activity a week, or 75 minutes of sort of higher level of aerobic activity. And this has been shown to be able to decrease breast cancer risk by about 25%. Increasing fruit and vegetable consumption. There's been some data there, as well as limiting alcohol consumption. And in terms of exactly what the exact diet is, or the exact number of drinks of alcohol that's okay, I think is less well known. I think the point isn't to focus on, a certain number or very prescribed diet. I think in general, it's more exercise, more fruits and vegetables, and reducing alcohol consumption in general. There are a number of studies showing that what we call chemoprevention, or drugs that block estrogen, can reduce risk of developing breast cancer. So tamoxifen, aromatase inhibitors, these are the same drugs that we actually use to treat breast cancer, but we do know that in our higher risk population, if patients take these medications, we can reduce the risk of lowering initial diagnosis of breast cancer. And then, of course, prophylactic mastectomy or mastectomies in patients who are at high risk. Next slide.
And actually, I think I'm going to have us pause right here for a minute. I want to actually switch and have Morgan tell us some of her story. And then I know that you have some more slides on screening and decision making, and I'm hoping we can come back to that as a discussion. I know that's what a lot of folks are interested in, is how to make those decisions. So let's switch over to Morgan and hear from you and your experience living a lot of these numbers in real life and what this has meant.
Hey guys, can you hear me okay? Yeah? Okay, good. Just making sure. You guys, thank you so much to Stephanie and Jen James and the wisdom study and Dr. Chin for having me. I'm really excited to be here today. And like, look at all the people on the call. Like, is this not amazing? This is amazing that we have all of these women that are tuned in. So thank you. Thank you for sharing, you know, your evening time with us, and we really appreciate it. So I'm Morgan Mitchell. Some people call me Dr. Morgan Mitchell. Morgan is fine. But it's really interesting. I have an interesting story because so the pandemic started, right? The COVID pandemic started, we'll say about March, April of 2020, right? That's really when it kind of started. And at the time, I was in my 7th year of my PhD studies in biochemistry. And I was trying to graduate. So I was writing my dissertation and trying to, you know, figure out my thesis presentation and all of that. I'm wrapping up. And so when the pandemic hit and they said stay at home, I was like, oh, cool. I could stay at home because I need to write anyways, right? Because I'm done with all the research. I'm done with all the experiments. I just need to write. So I was like, oh, this is great, right? And then it wasn't so great because I defended my thesis in May orally. I submitted my written thesis in June, right? This is all 2020, right? And then in July of 2020, I just happened to brush up against my breast and I felt a lump. And, I was 34 years old. My mom doesn't have breast cancer. Her sister doesn't have breast cancer. My grandmother doesn't have breast cancer. It was not expected at all. And I honestly I call it divine intervention. And I also have to thank COVID because COVID put a stop to everything. So we were able to pay attention to things that we weren't used to paying attention to. If COVID wasn't there, I probably would have brushed my breasts and just whatever, went on about my day, busy day, doing errands, whatever. But COVID stopped everything, right? So I felt something and I was like, no, whatever. The next day, I felt it again. And again, divine intervention in COVID because I was 34 years old at the time. I was not doing self-checks. I was not, breast cancer was not even on the radar. Not even, okay? So, the next night I felt it. I said, wait a minute. So I go to my mom's room and I said, feel this. And she said, yeah, there's something there. Make an appointment with your OBGYN. So I did. I made an appointment with my OBGYN and she was like, oh, wow. She's like, yeah, there's something massive here. She's like, however, given your family history, your lack of family history and your age, is probably just a cyst. Cysts are common. Breast cysts are common. Also, if you have fibroids, uterine fibroids, these are very common in women of color. So she was like, I've had 3 in my lifetime. Nothing to be worried about. She said, but we're gonna check it out. I said, okay. So then she connects me to, she's a Black woman. My OBGYN is a Black woman. And she connects me to, she said, my colleague, she's a breast surgeon. When I looked her up, when we did the research, she is the top breast surgeon for women of color in Texas. And I'm from Houston, Texas. So she said, she's the one that has done all of my cysts. She said, I love her because she respects the aesthetic of the breast. She doesn't leave you looking mutilated or cut up. She understands that, you want to walk out of that surgery, with some sort of self-confidence. And this is important. The psychological factors that come into breast cancer, That's important. And at the time I was single, and I was like, okay, I can't be cut up looking for my husband, like, no, and also for yourself, like you want to feel beautiful for yourself, and you see these pictures of women who just look like they've been mutilated, right? And it's traumatic. It's really traumatic. And she said, no, she takes careful care in ensuring that the scars are minimalistic, that she only has to remove what she needs to remove. And these things are important, right? So, yeah, I felt a lump, and she referred me to the breast surgeon. When I went to her office, she felt it and she was very concerned. And she said, Morgan, this is very large. And at the time it was almost 5 centimeters, which is considered a very large. So when we talk about large tumors and them growing and progressing really fast, especially in young women, that's what happens. I had a very aggressive form of breast cancer, HER2 positive, ER positive, estrogen positive, and progesterone positive. And that's what tends to happen, is that younger women have very aggressive cancers, and they spread very, very fast, like very, very fast. Just like Dr. Chin was saying, oh, this wasn't here 2 weeks ago. Literally, it wasn't there 2 weeks ago. This wasn't here last week. It happens that fast. And I've heard of several stories where women, because you only get a mammogram once a year, and I've heard of several women who have gotten and been diagnosed with breast cancer in between their mammograms. That's how fast it spreads. So we need to know this. We need to be aware. And so going back to my story, she said, my concern is that it's cancer because it's so large and it develops so quickly. Now, this is my first time ever seeing her in life, my first time meeting her. And she's like, this is very large and it has obviously developed very quickly. So she knew, she understood. She said, we're going to do a biopsy right here now. She did the biopsy. 5 days later, over Zoom, she told me that I had breast cancer over Zoom because we're in a pandemic. I was not expecting it. I was expecting it to be a benign cyst. I was not expecting it at all. Again, my mom's side of the family doesn't have breast cancer. Now, my dad's side of the family, there are some distant genes where some people have breast cancer, but I never thought breast cancer, it wasn't even on the radar, not either. And I was diagnosed with originally stage 2, and then they downgraded it because it had moved into my lymph nodes. So your lymph nodes are like under here, right? So, and that's important because your lymph nodes, they communicate with the rest of your body. That's how stuff travels, right? That's how cancer travels. That's how any disease spreads. It goes through a vessel. It may go through the blood system, the whatever system, in this case, the lymph system. That's how it travels throughout your body and infects different parts of your body, right? That's the spread of cancer. And it was a large tumor. It was considered a large tumor because it was almost 5 centimeters. And it had spread to, originally, they said it had spread to one of my lymph nodes, just doing, their preliminary check when I went in for surgery. So they actually don't know, the exact number until they actually go in. And so when they went in, it was actually 3 lymph nodes, and I had to have all 3 of those removed. And so imagine this, right? So the pandemic starts in May, April 2020, right? I literally graduate. I received my PhD in August 2020, and later that month, I received a breast cancer diagnosis in the same month during a pandemic. I was terrified out of my mind, because this was before vaccines. This was, you know, we were going crazy as a global population. We didn't know what to do. People are dying. People are in the hospital. They're saying, don't go out. Like, we've never experienced this before. It was crazy. The psychological toll that took was very, very hard. I was scared for my life every day. I never left the house. I didn't feel comfortable leaving the house. I only left the house to go to cancer treatment, and that's it. Nobody could come close to me. Nobody could touch me. And it was really hard, because that's all I wanted, was somebody to hug me and be like, it's okay. But I couldn't do that. You know, it was hard. I didn't even feel comfortable going to a public park, because I did not feel comfortable around people at all. I went through chemotherapy for 6 months. I did a lumpectomy, so I didn't have to do the mastectomy because it was still kind of local, right? So I just did the lumpectomy, where she removed the lump and a little bit around the lump. And you know, it was hard, because again, you know, you have these body image issues, right? And so when they took off the bandages for my surgery, I was hyperventilating. I was like about to pass out. I was like, because I was so scared that I was going to look down and just see myself chopped up. And that was hard. I was hyperventilating. I was going to pass out. They had to give me water. They were like, okay. And then the nurse was like, oh yeah, girl, your stitches look good. I've seen people and their stitches look bad. You're good. And so I was like, okay. And I looked down and I was like, oh, I'm good. Right. It was just a small incision, small scar. And again, I have to give credit to my breast cancer surgeon, because, you know, I think a lot of doctors are trained to, you know, we're going to do whatever as long as the cancer is out. And that's good. That's good. That is the main goal, is to get the cancer out. But as a woman, as a person, as you know, as a young person, you know, that is very important. You know, that brings a psychological toll in and of itself, these body image issues. So, you know, it's important. I mean, we can't sweep it under the rug, right? We need to address all of these things. Yes, get the cancer out. Yes, make sure that I survive. Yes, that's first and foremost. But understand that, you know, this is my body. This is my breast. This is me. You know, I look in the mirror and I see me. And so these things are very important. And so after the lumpectomy, I went through radiation. And then I went on what's called maintenance therapy. And so I had a very bad reaction to the maintenance therapy drug. So basically, after you do chemo, after you do surgery, after you do radiation, maintenance therapy is to prevent reoccurrence. It's to prevent it from coming back, right? And I had a very, very bad reaction to this drug, to the point where I had nerve pain so bad in my feet, I couldn't walk. I was bedridden for a month. I had to get on a wheelchair. The pain was so intense. I wouldn't wish this on my worst enemy. It was nerve pain. Yeah, because that's internal pain. You know, it's not like you hit your foot on the corner of the couch. This is internal pain. Like, it's like, it feels like needle. Every time I step on my feet, it feels like needles penetrating through my feet and through my legs. And there's really no medication to help with that. So they put you on opioids. So I was on opioids. And we all know the problem with opioids. They are highly addictive, and they can become addictive very, very quickly. So after 2 weeks, I stopped taking the opioids. I said, no, because that's just going to cause, I don't need to be a cancer patient and an addict at the same time, right? Like, no, right? So then after that, I'm still dealing with pain, right? And so you have to understand, like, breast cancer, any type of cancer, you know, there's residual effects and they may be different. They vary from person to person. They took me off that medication, you know, and they were really, really worried. My oncologist was worried. My radiation doctor was worried. My breast cancer surgeon was worried because I was so young and I was basically, you know, couldn't walk. I was in a wheelchair, you know, and they have to try and correct the problem. And the thing about these drugs are, right, these drugs are heavily into your system, right? So it's going to take time for them to get out of your system. We're not talking about aspirin, okay? We're not talking about Advil, okay? We're talking about drugs, heavy drugs that have been pumped into your system for weeks at a time, which means it's going to take weeks at a time for them to filter out through your body, you know, and I just had to endure that. And of course, you know, thank God I got better and everything like that. And, you know, you guys, I'm just really glad to be here. I'm honored to be here. I'm honored to talk to you. I'm really, really passionate about young women and breast cancer. I'm really passionate about young Black women in breast cancer. And I'm really passionate about young Black women with breast cancer that don't necessarily have a family history, that weren't expecting it. I was not expecting it at all, at all. The current standards for a lot of medical societies, a lot of medical colleges, you know, a lot of organizations, the current standard is if you have little to no breast cancer family history, you get your first mammogram at 40 years old. I was diagnosed at 34 with little to no family breast cancer history. If I had waited until 40, I would be dead. So
I think, so I was just gonna say, and more, I just want to echo your statements. Like, we're all so glad that you're here too. And I think, you know, that just speaks to how important it is when you feel something to seek out care, which we know not everyone can do. And, you know, you talked about both the silver linings of the pandemic, but we know so many people weren't going in when they felt something during the pandemic. And your story speaks to that so clearly. But I do think this question of when to start screening, how often, who needs the screen is when we want to turn back to. And I want to bring Dr. Shan back into the conversation too, because it's so hard. I think you both, you know, we hear what happened to Morgan, which is what, you know, Morgan and I are the exact same age. And like, that's scary to think like, oh no, should I be screening? But then also hearing like your cancer probably wouldn't have been caught on screening. It happened so quickly, right? Unless you happen to be getting a mammogram that week, you know, would it have made a difference? How should, both on a population level and on an individual patient level, how should we be making these decisions about when to start screening, how often to screen, thinking about women in their 30s and their 40s?
You know, I might make a comment here, Jen, because that is exactly what we're trying to, that's exactly what we're trying to do with the Wisdom study. And in fact, we're designing the next generation, what we call Wisdom 2.0. It turns out that, you know, that one of the things that we know is that people who carry a mutation in one of the 9 genes that predispose you to breast cancer, 2/3 of the people who are positive didn't have a family history. Now for BRCA1, which is the most strong predictor, even there, 1/3 of people didn't have family history. So one of the easy things for me to say is like, for goodness sakes, let's get the low-hanging fruit. Let's make sure that everybody's that you know, this test that we can do when you are, we can do it when you're 30. There's no reason to wait till you're 40. You can start when you're 30. So at least the people where we know. So there's a couple of things we're trying to do. One is those mutations. That's not very common. But there's another thing. Who is at risk for these fast-growing tumors? We're trying to develop specific risk markers just for that and start to screen. It won't be perfect the next route out, but to try and find out and learn about people like you, Morgan, what are these things that we can learn to start to do better and screen twice a year with contrast-based imaging. I think we have a chance of not having them come in between. And Joe and I can say this, from the I Spy trial, which is a trial really specifically for people with large tumors. 80% of these people are not screen detected because they're either early, they show up in between. I always say when I talk, the most important thing, if you're a woman and you feel something, go in and get it checked out. Don't ignore it. And if you had a normal mammogram 8 months ago, don't say, oh, I had a mammogram, I'm fine. That is not it. And during the pandemic, where we had the biggest problems were people who didn't come in when they felt something. It's a much bigger deal than the people who missed their mammograms. And so these are the things that we're trying to change. Can we do a better job? And can we really concentrate the resources a little bit more so we're doing more for the people at highest risk and really less for the people at lowest risk? Do I know for sure we can do it? No. But if you don't try, you're stuck with where we are, which clearly isn't acceptable. We can do better. And, and it's different. I think the risk factors or the genes that put African-American women at risk are going to be different from the genes that put Latino women at risk and, white women or Asian women at risk. And so these are the things that we can start looking at. And that, of course, is why it's so important for everyone to participate. Because if we leave a group of people out or they're afraid to participate in one of these studies, we're going to miss the boat.
Yeah, Dr. Esselman, I agree with you. However, I tested negative for all of the panel of breast cancer genes. There's no
but we didn't
mutation.
we're looking at something else, right, called polygenic risk. So we're trying to look at the many hundreds of genes that you also inherit and specifically look at markers. The ones that are out there now tend to predict lower risk tumors. Not that helpful. That's not the kind of tumor you had, but that's not surprising, right? Because most tumors, right, that's the majority of tumors. But we specifically want to look at the kinds of cancers that African-American women are more at risk for, and see if we can work. My colleague Fumi Alapade has some specific predictors that she think will work in the African-American population. Alad Zev has been working in the Latina population and the Asian population.
But I want to let Morgan finish her point though. And Morgan, correct me if I'm wrong. I think there's the point that risk prediction is never going to be 100%, right? So there are lots of people. So go ahead, Morgan. I don't know if you had more you want to say.
Yeah. I mean, I'm a breast cancer patient, so I have a very different perspective on it. I appreciate everyone's perspective, but if you just focus on high risk, you are basically abandoning and neglecting everybody else. And I'm part of that everybody else. And I don't know if you heard this quote called, "It's rare until it's in my chair." If I'm one of 1 million, I really don't care what the statistics are. That's me. This is my life. If I'm 1 in 500,000, I really don't care what the statistics are. I'm the one. So yes, of course, healthcare and medical care is always going to target the high risk, the most common population, everything. But again, I'm part of that other population. This is my life. This is my life, and the thing is, most people, I mean, let's be honest, you're not going to do genetic testing. First of all, genetic testing, the insurance has to approve it. Even after they confirmed that I had breast cancer, they initially denied, my insurance company initially denied genetic testing. So
So-
imagine someone who doesn't have breast cancer and you're trying to do genetic testing. That's not gonna, it's not gonna get approved. Let's be honest here.
So wait a second. That's what the wisdom study is doing. We are actually testing anyone who signs up. I can't tell you for sure that this is going to work. If it turns out to work, it will get covered. But
Yeah.
that's it. And I don't know. But again, there are two things. You are correct that even if we improve and find a better thing, it might not find you. But there are two important things that we have to do. We have to do better with what we've got and keep working on finding out what drives risk in people like you. And again, especially in HER2 cancers, I mean, the flip side is Joe and I also work on a trial where we are really intent on trying to figure out what the best treatments are, because once you've got it, the most important thing is figuring out what's going to work to make it go away. And sounds like you had your treatment, the chemotherapy before you had the surgery, right?
I did.
Yeah, and that's the right thing to do.
Which is now the standard, which is now what they do.
Right, it is the
Back in
standard.
the
and
day,
it
they used to
also-
do the surgery first.
Right, and I'm a surgeon and I can tell you the right thing to do is the other therapy first, because
Yeah.
then the amount of surgery you can do is a whole lot less.
Right, you
And
want to shrink the tumor first.
right, and understanding that tells you you've got the right treatment, which is, and we hope over time that it will help us figure out how to hone in and give just the right amount, not too much, so we don't cause those terrible side effects that you had. I don't know, Joe, if you want to say anything about that.
Mhm. Yeah, and
Yeah.
I just want to end, or not necessarily end, but just back you up, Dr. Esserman. Yeah, everything you said is correct, Dr. Chin. Everything you said is correct. But it's very hard when you don't have those risk factors and then you end up with breast cancer. I'm in that group. So it's very personal to me. And I agree with you, Dr. Esserman. It starts with exposure. That is what, that is part of my purpose, my God-given purpose. That is part of my story. I'm a young Black woman. I look like a lot of young Black women. I don't have the history of breast cancer. And I was diagnosed at a very early age when I wasn't expecting it. I agree with you. Yes.
And we actually have a trial that we're trying to find people like you.
Mhm.
Donate a little core biopsy piece of tissue so we can understand, is there something we can learn
Yeah.
about
And-
your
and-
tissue, that what makes women under 35 at risk? And we're specifically looking at African-American women.
Yeah. And I
Yeah.
think the more important thing is that, we have to acknowledge and spread the word that breast cancer is not your grandmother's disease. That's what I thought it was. I thought it was just for old women. Okay. That is not the case.
And a lot of women also think that mutations are only in white women or Jewish women, which is also not the case.
Yeah, I tested I didn't have any mutations for the entire breast cancer panel. But my goal is to, just like this right now, this forum is important because we're talking about it. We're communicating about it. That's the first step. We got to talk about it. We can't sweep it under the rug. We got to talk about it. So this is one of the first steps. The second step, I believe, is because women are getting diagnosed earlier, that means the education and awareness needs to start early. And I believe we need to start at puberty. We need to start with self-checks. As you mentioned, Dr. Esserman, knowing your body. You know when something's wrong. You may not understand exactly what's wrong, but you're like, something is off, and we need to teach young women, about breast self-check. It takes 5 minutes.
And I think that's a
Takes
good
5
point. And
minutes.
somebody raised this in the chat too, and it's a question I had. I feel like, now the message I've heard is we shouldn't advertise doing regular self exams. I remember when I was young, when I went through puberty, it was like every month on your period in the shower, and you had a little card that reminded you to do it. And now they say, no, it's just being familiar. Self checks aren't helpful. I've seen things about clinical breast exams aren't necessary if you aren't high risk. And I think this is confusing to a lot of people. What is the message, or what are folks, what should folks be doing who want to feel like they have some control, they're doing something for their breast health?
So Jen, I think this is an unfortunate miscommunication. There was a couple of studies that really looked at these like 30, teaching people to do these extensive self-breast exams. And that actually caused a bunch of false positive biopsies, a bunch of stuff. That's very different. I actually think the UK has a very good way of doing it. They have this campaign that says, be breast aware. Just doing, a 30-second check and just being familiar what your breasts feel like. This is good for everyone, because there's still 30-40% of cancers are found by women themselves, regardless of screening. And it is a message that I think is so important. If you feel something, you know best. If some physician tells me someone's got a mass, I'm not as concerned as when someone says, wow, I know I felt something new. Almost always that is something, because if you know what your breasts feel like and you feel something different and you come in, you got to pay attention. And if someone doesn't pay attention, you got to go find somebody else. It's such an important message. Be aware. And that, I always tell people 30 seconds in the shower, 1, 2, 3, 1, 2, 3. 10 seconds in the shower, honestly, once a month, same time of the month, it's good. Be aware.
If you feel something, say something.
That's right.
Well, and also I think it's important to continue to advocate for yourself, because even if you feel something and you get yourself to the doctor's office, and this is usually a primary care physician. And the thing is, when in medicine, we're taught this balance of, okay, what is the most likely on the differential? And as a young woman, you come in with something that you feel, for most people, breast cancer is going to be low down on that list. But as you say, Morgan, that for you individually, and for all the patients we see in the clinic, for them, they were the one in whatever, right? And so how do we not, overtreat so many patients, but catch the ones that really need to be caught? And sometimes when a patient comes in, we've seen, primary care physicians will say, well, this is not worrisome, we can follow this. And, that's not inappropriate in many cases, but the important thing is that there is very close follow-up. I've seen many patients, when they're diagnosed, where you go back in the history, and yes, they went to see their primary care physician, and maybe they said, oh, this looks like it's an infection or it's a cyst. And maybe that's okay for a couple of weeks, but there should be very close follow-up. And if that's getting bigger, or if it's changed, or it's not better, then, you got to escalate to the next thing. In other instances, it should be biopsied right away. But I think these kind of, sometimes it's like, oh, it's probably fine. And then patients are sometimes just kind of, they come back in 6 months, or they say, wait to the next. And, and they've said, oh, my doctor was reassured, but, just if it doesn't seem right, if it's, the gut is a very powerful tool, call back, keep pushing, because as Dr. Esmond said, your body the most, and we in the breast cancer clinic, all we see are the 1%, because they all were diagnosed, and we've seen all the stories of how they got there. And we know in young women, there can be some delay because of that, because it is unlikely, but we know that for patients who have it, that was your one.
Yeah, definitely. I agree. I am so about being your own advocate. I before diagnosis, I was not like that. I was not my own advocate. If you think about it, it's kind of like, I didn't go to medical school. I'm not a doctor. That's what I'm paying you to do. And I expect the best care from you. And you do often provide the best care. However, you have to be, as a patient, you have to be your own advocate, because like you said, Dr. Chin, you guys are taught to look at what is likely, what is probable, what makes sense. And that's good. I mean, that makes sense. But, you know, as a patient who didn't have a lot of risk factors, who wasn't really considering this, and to be diagnosed with almost stage 2 breast cancer when I was 34 years old, like, this is my life. This is my story. This is my testimony. So it's very personal. And you have to be your own best advocate. Like you said, keep bugging them. You know when something's wrong and when something's not right. Get it checked out. Get the that you're okay. Get the confirmation that no, you're not okay, which is very hard to do. You know, Jen James, you talked about this. Let's be honest, insurance companies are not going to give you genetic testing, like, and it's expensive to do it on your own. Like, you have to think about our healthcare system, right? So it can be very, very hard. Again, breast density, most Black women have high breast density. I was diagnosed with high breast density, which can make it very, very hard in a mammogram to visualize and locate a tumor.
You know, I want to say something about genetic testing. It turns out that there are a number of people who sell genetic tests, and they range anywhere from about $225 to $2,000. And I can tell you the ones that are very inexpensive are just as good as the ones that are very expensive. The ones that are very expensive are there because they were kind of dominant in the market. But some of these newer ones, in fact, you know, we partnered, one of the reasons we partnered with Color Genomics is because I was looking for a way to get high quality genetic testing, a standard part of risk assessment across the population. And if you have something that's less than the cost of a mammogram, you can do that, which is why we partnered with them. And it is available. And I think a lot of people don't know about it. I think a lot of physicians don't know about it. I think a lot of hospitals wind up knee-jerk defaulting to tests that are very expensive. It's very frustrating to me. And then I feel like these things should be and could be so much more accessible. Again, that's one of the reasons why we're trying to do this study. We're trying to raise awareness and trying to push, you know, a different way of thinking about it so that we can get better. We're not going to solve all the problems, but we can't just keep doing the same thing we're doing and hoping that somehow it's going to be better. Right. So we want to get there and, you know, get the word out. And that is one of the things that, you know, I would say again, you have to advocate for yourself. Any young woman under 35 with a new diagnosis of breast cancer, it is standard of care. It's part of the guidelines to get genetic testing, even under the age of 40, increasingly. And increasingly, there are drugs that target people with mutations. So I actually think that within the next 2 years, it's going to become part of the standard of care, and we should not be fighting over this, you know, seriously. And so I, you know, again, it's something that I want to make sure that everybody knows about.
Yep.
And that you know, it is, you know, there are laws in California, and we're trying to make this, you know, part of the national law, that if there's a trial that's open at a site and you want to go participate, your insurance has to cover your standard of care cost to go. Now, no one's going to raise their hand and say, oh, let me cover that for you. They are not. You have to fight for yourself. We fight for every person to be able to come here, and we have to send them a copy of the bill. That's part of good healthcare, unfortunately, is, again, as you said, and Joe said, you have to advocate for yourself.
Yeah,
I think something
forums is to make sure that people are aware so that they know how best to advocate for themselves.
I was going to say that's something we sort of, I think, talked about as a topic potentially, and we're over time. Thanks everyone who's done the poll.
How to advocate.
Allison has also put in links to the surveys, but I think a great topic is how to advocate, potentially, particularly like pre-diagnosis. I think there's a lot of folks who, especially thinking about younger folks, you might not have a regular PCP. What happens when you're in between insurances? What happens in different parts of the country? What are the questions you need to be asking? I think once diagnosed, a lot of places now, there's navigators, there's resources. What do you need to know if you're just going in for your annual exam? How to advocate, I think, is a great topic. The other thing I think I'm hearing a lot, or I heard a lot today, is sort of this distinction between what do we do for the population and how should I think about me, and I might be the one in a million, and how we balance those things in research, I think is great. And I'm seeing just so many questions in here about genetics and genomics, some things about what influences our genetics, which is great. So we have so many great topics. We're going to continue. I think we should talk about making these longer than an hour. There's always too much to talk about. So if you'd be interested in talking to us for more than an hour a month, let us know. But thank you so much.
And Jen, I just want to answer one question.
Yeah.
Breast cysts are not a precursor to cancer.
Great. No more information, more knowledge is power. So yeah, join us in September. We're going to be talking about breast cancer and menopause, which is one of the topics here that some folks expressed interest in. So sort of continuing our Across the Life Course series. And yes, just a huge thank you to Dr. Joe, to Dr. Laura, to Dr. Morgan for being with us today. And I hope you all saw the love in the chat for being willing to share. It's very appreciated. And we will see you all next month. Reach out anytime with questions or with ideas for what we should talk about in future forums.
I like your idea, Jen, how to advocate for yourself.
Yeah, I think that's a great one.
It's a great topic.
Thank you, everyone.
It's hard to know. And I think also just note, I think it's different in different populations. If you don't have insurance, if you're a person of color, how you're viewed or what your possibilities are, I think it's important to have those frank conversations about how do I make sure my doctor doesn't think I'm angry when I'm advocating, right? Like there's a lot of things to consider.
A lot of things to consider. And just real quick, I know we're over time because the quote, advocating for yourself, what does that mean? And, I'm a scientist myself, but when I go into the doctor's office, I made sure to have my brother there with me because I was in shock most of the time when they were communicating with me. I had my brother there. He came with questions. He came with a notepad. He came with a pen.
Absolutely.
He wrote everything down. He took notes because as a patient, you're in shock. And I'm a scientist and I'm a patient and I was just in shock. I couldn't remember a lot of the conversations because you're traumatized. So making sure that you have someone with you is one way to advocate for yourself and be your 100%. Own self-advocate.
We should get Jeff Belcora to do a session about how to prepare a question list. I mean, this is something we actually do for our patients here, but she has a whole method. So if you don't have that service, how do you prepare a set of questions and ask to record the conversation? That's your right.
That's great. That's great tips. I mean, because again, you don't know what you don't know. How do you know what to ask? How do you know what to do?
Yeah, but let's do that.
These are important conversations, and it starts with this right here, these forums: exposure, awareness, asking questions. I've learned so much already. To be honest, I've learned a lot here, and so that's proof that it's working. We need to have these conversations. We need to have them often. We need to be vigilant. We need to be aware. We need to be aggressive because this is cancer. Okay, it's not strep throat. Okay, cancer is designed to kill. So we have to be on the battlefield ready. And I feel passionately about that. And thank you so much, Dr. Chin, Dr. Esserman, and Jen James for putting this together because it starts with conversations like this. And I really appreciate this.
We're so grateful to have you here sharing your story and for your leadership in this area. It's cancer should be scared of you. That's what, you know.
Okay, great.
Thanks
everybody.
Bye, guys.